All right, we'll go ahead and get started. I know folks are still joining us. So good afternoon, everyone. Thank you for being here. My name is Elizabeth Gonzalez. I'm the Associate Director for Birth Equity here at EverThrive, Illinois. And today, for today's town hall, we have addressing perinatal mental health, symptoms, prevention, treatment, and symptoms, prevalence, treatment, and prevention. And today we do have a guest speaker. We have Lita Semanis from Ascension. She will be our guest speaker and walking us through a discussion with us. So I will go ahead and just continue. Oops, sorry. All right. And so this slide just discusses a little bit about EverThrive Illinois' mission, vision, and values. So again, for all those that are new, EverThrive, our mission is to achieve reproductive justice in the healthcare ecosystem through community-driven partnerships, policy action, and systems change. Our vision is a just and affirming healthcare ecosystem where individuals, families, and communities can thrive. Our values are reproductive justice, anti-racism, centering the most impacted, and bold action and transformation. Just a few reminders before we get started with our guest speaker. Please keep yourself muted to reduce any background noise. A follow-up email with materials will be sent to all that have registered, and that includes our PowerPoints and any meeting notes that we may have for you. Please feel free to type any questions that you may have in the chat box as we go. There will be a question and answer session at the end of the presentation as well. So yeah, I would say just save any questions that you have for the end, and we will get to them once our presenter is done with her presentation. So for today's agenda, we will have introductions. I'll introduce our guest speaker. The topic for today's town hall is addressing perinatal mental health. We'll then move into any resource sharing that we have, and then we'll wrap up. And then there is a short survey that we have at the end for you all pertaining to the town hall. Our guest speaker today, her name is Lita Semanis. She has collaborated with the Ascension Illinois / Alexian Brothers staff and other stakeholders to develop the first perinatal intensive outpatient program in the state of Illinois that has opened its doors as of August 2015. She's also a perinatal crisis counselor for the Illinois Moms Line, and she's on the board of directors for the Postpartum Support International. She's the co-coordinator of the Postpartum Depression Illinois Alliance. Lita has also lectured on perinatal mood disorders in local and state and national and international settings. She has been involved in advocacy, providing expert testimony in support of Illinois House Bill 1764 that allows for perinatal mood disorders to be considered as mitigating factors for sentencing in crimes. Lita is a member of the Illinois Department of Public Health Maternal Mortality Review Committee on Violent Deaths. She was part of the team of subject matter experts that developed the perinatal mental health certification exam. So I would like to welcome her. And yeah, we'll go ahead and we'll get started.
Thank you. Thank you for that introduction and welcome everybody. Thank you for your interest in this topic. I am going to go right into my slides and share those. And just let me know if I need to change anything. So I'm going to start with my own acknowledgements. First, I'd like to let you know that I'm coming to you from Hoffman Estates and would like to gratefully acknowledge my location on the ancestral lands of the Potawatomi, Ho-Chunk, Peoria, and Kickapoo tribes. I'd like to respectfully acknowledge the survivors and the victims of perinatal mood disorders, past and present, and their loved ones. And of course, I'd like to thank EverThrive for this opportunity to share knowledge and improve outcomes for parents and families. So our objectives today: recognizing signs and symptoms of perinatal mood and anxiety disorders, the prevalence rates and risk factors for developing perinatal mood and anxiety disorders, and then the treatments for what we will call PMADs, and discussing opportunities to prevent effects of PMADs and prevent the illnesses themselves. This is the declaration for the month of May from our governor for the state of Illinois to recognize May as Maternal Mental Health Awareness Month in Illinois. And this is the 20th year that we've done that. And this is thanks to Dr. Sarah Allen from the Postpartum Depression Illinois Alliance. So just to be aware that Illinois is doing some positive work, and we've done other things as well that I'll be mentioning in our talk. So I'm glad that you're here to recognize Maternal Mental Health Awareness Month. Even though we're going to be talking a lot about statistics and prevalence rates and signs and symptoms, I always like to remember that we're talking about people, and to share at least a story or two. So this story comes from the website Postpartum Progress, where they invited folks to share their stories based on the phrase, "You can't tell by looking." So Adrienne wrote, "When this picture was taken, I was suffering through severe postpartum depression. You can't tell by looking, but just hours before this picture was taken, I tried to kill myself. I had been sobbing for 2 weeks. An hour after this picture was taken, I got up on stage and performed for a church talent show like everything was fine." And that really highlights one of the reasons why we need to do the work that we do. Moms really, work hard to do well. So a few definitions just for clarity. Perinatal or peripartum, the time frame from pregnancy through the first year after giving birth. In other venues, the time frame might be different. They might say 4 weeks, as we see in the DSM-5 down below. They say only 4 weeks after birth. The World Health Organization defines it as 6 weeks after birth. But clinically on the ground, I think what we all see is a year, and sometimes even beyond that, is really a perinatal period or a peripartum. And then prenatal or antenatal means during pregnancy, and postpartum or postnatal, again, first year after birth. If you are doing research in this area and want to be very inclusive, including that word puerperal in your searches is important, because that's the British term for perinatal. And then we're using PMAD. It used to be PPD for postpartum depression. We want to be inclusive of all the mood disorders. And then, as I mentioned, the DSM-5, the Diagnostic and Statistical Manual of Mental Health Disorders, does say only 4 weeks after birth, but we recognize it to be about a year clinically. And whenever appropriate, I do strive to be inclusive by using the term birthing person, but also work to accurately represent research data. So that may focus on women and maternal mental health. So sometimes the definitions and the terms flow back and forth. And also, just to be clear, that whenever possible, I will try to outline if I'm talking about things that are in reference to research, or if I'm talking about things that we see clinically. So just starting with some of the facts of deliveries in the US in 2022, we had well over 3 million deliveries. And if we talk about the rate of about 15 to 20%, we're looking at nearly 1 million women each year just in the United States that will experience perinatal depression. Comparing that with the rate of gestational diabetes, which is about 10% according to the CDC, this is what we call the most common complication of childbirth. It behooves us to recognize it, to understand how to treat it, to understand how to support families who are experiencing this, especially because although a lot of people realize something is wrong, a lot of them will also not report this to healthcare providers. So we need to be able to make that space to show that we are comfortable and open and wanting to talk about this and inviting people to share this information. As Karen Kleiman writes, she's the person who has that postpartumstress.com website. Sometimes women will scream for help, but sometimes they just hope that no one will notice, or they hope that this will just pass and this will just get better. So it's important for us to be out there. I'd like to first mention baby blues, because people still do conflate baby blues with depression. Someone might say, oh, yes, I had a really horrible, baby blues experience. It lasted a week. That's baby blues. That's correct. They might say, oh, it lasted 6 months. That's not baby blues. That's something much more. So understanding that this is a common experience. So prevalence rate is very high. It typically doesn't interfere with functioning, and it resolves on its own. It's really a hormonal experience. A lot of women will report that they're just feeling like they're crying for no reason, or they don't know why they're crying, but they are able to experience joy. Treatment should really be in quotes. There's not really any formalized treatment needed, just sort of self-care 101. But to recognize that some women will go on to experience a perinatal mood and anxiety disorder when they start with the blues. So the prevalence rates for postpartum depression, we're going to see prevalence rates range, pretty significantly, and that's because research is done very differently. And so it may be the group of people that they're studying, it may be the way that they're studying it, and maybe the way that they're measuring the data. So it really depends. So prevalence rates for postpartum depression can range from 12 to 25 in the data. We kind of stick with 15 to 20 as the range, professionally. One of the things that we see a lot is that for a lot of people, this is the first time they're experiencing a clinically significant case. They may say, I had a little bit of anxiety in college, or I was a little bit depressed as a teenager, but this is nothing like that. It's a lot more significant. So it's important to be able to, again, provide that information that this is something that is recognizable and treatable, and we want the treatments to be taking place. Someone who has a previous history of major depressive disorder has an increased risk of 30%. Someone with a previous history of postpartum depression, especially when untreated, has an increased risk rate of 70%. And then in higher risk groups, we might see rates as high as 40%. So that may be ethnic minorities, that may be folks in lower socioeconomic status. And again, most common complication of childbirth. You might hear me say that a few times. Some of the symptoms that we see, and according to the DSM, this is within 4 weeks, but again, clinically, we look well beyond 4 weeks. Despondency, sleep disturbance, fatigue, irritability, difficulty concentrating, feeling inadequate, feeling like I'm just a bad mom, I don't know what I'm doing, I can't get this right. And then ego dystonic thoughts of hurting the baby, which we'll talk about in more detail. But ego dystonic means it doesn't fit with who they are. It doesn't fit with their identity. They don't like having these thoughts. There's definitely functional, occupational impairment, feeling like I can't do what I want to do as a parent, feeling like I'm not being a good partner, feeling like I can't concentrate and get what I need to get done at work. When we see subthreshold symptoms, so someone who may not be necessarily meeting criteria, we still also want to get involved so people know that if symptoms get worse, we want to be in their world and giving them resources. And we want them to know what to keep watching for, or if maybe they already need to start getting some support. Recognizing that non-Western cultures may describe their symptoms in very different terms. In one study from Ghana, they talked about thinking too much, or they may talk about physical pain. So being aware that it can look different with different people. So the diagnosis from the DSM, again, there's no specific diagnosis. There's no specific group of postpartum illnesses at this time in the DSM. There's only specifiers. So we add the postpartum specifier, but the criteria is that there must be a low mood, anhedonia, a change in appetite, sleep issues. So 5 of these, the baseline is low mood and anhedonia, and then we want to see 5 of change in appetite, sleep issues, psychomotor agitation or retardation, fatigue, low energy, worthlessness, guilt, and possibly thoughts of suicide. So we're adding that postpartum onset criteria. We have to rule out psychosis, physical symptoms. We have to rule out alcohol or drug use. And there is an ICD-10 code that we can use, F53, for postpartum depression. I think it's really more helpful to look at themes. I think we all know how to diagnose, and we can, look to resources for diagnosing. But what we might hear from moms, from people who are birthing parents, birthing people, is some of these things. So irritability might be a big one. Someone might say, I know my partner's trying to help me, but I can't stop yelling at him. They might say, why am I just getting, to lose my cool with my 4-year-old? So then they feel shame and guilt for having those experiences as well. We might hear a mom say, I just wish I could get in my car and drive away and never come back. And they may report that as suicidality, but that's not necessarily suicidality. So understanding suicidality is very important, because unfortunately, as we will see, moms do complete suicide. But it is very important to understand that sometimes they will say, I'm having these thoughts, and they're really much more escape fantasies. And being able to normalize that can be very helpful to say, we know that you don't want to leave your baby. We know that you don't want to, you know, do something that's harmful. But you're just tired of feeling crummy, and we want you to be able to feel better. So speaking of guilt, there's a lot of guilt. I think parenting is, unfortunately, you just kind of get guilt with parenting. But when you're feeling low, it's really hard to tease out what's something to pay attention to as far as guilt and what's not. So there may be a lot of guilt around poor functioning, about not being the mom that she dreamed of being, or just lack of enjoyment, feeling like I'm not bonding with this baby, I'm not enjoying this baby. So we do talk a lot about the theory of the good enough mother. If you're familiar with the theory of the good enough mother, it comes from Donald Winnicott, who was a pediatrician in England in the 70s. And it's really a way of understanding how to get off a hamster wheel of perfection. So being able to see that what our children benefit most from are parents who are imperfect, who have the full range of emotion, who sometimes cry, who sometimes get mad, but then are able to repair, able to say, I need a minute to myself. That's okay. It's okay to, take time for yourself when you need it. So the good enough concept has been used in other situations now as well. They talk about the good enough teacher or the good enough relationship. So it's really a way of trying to take away that need to try to be perfect all the time. Another theme might be, my partner doesn't get it. My partner's trying to help, but it's not helpful. So a lot of times we'll suggest, having some time to have psychoeducation for the partner. Also, the book, The Postpartum Husband, Karen Kleiman's book, is really helpful. She just reissued it as The Postpartum Partner. And it's a really nice tool. It's written in bullet points, easy to read, easy to digest, and for partners to be able to share with one another. Sleep sometimes is really the big thing. So sometimes sleep is significantly impacted due to hormonal changes, due to the circadian changes that come with childbearing. So understanding that even if baby may be impacting sleep, if rumination, anxiety, and worry is there, that may cause the patient to not be able to sleep, even when baby's sleeping. So that's what we ask about. Are you able to sleep when the baby is asleep? And if not, sometimes just targeting sleep and figuring out how to manage that and get that under control can be helpful. And recognizing that, we want to meet the person where they're at. So giving them reassurance and education where they're ready to receive it. It may not be that they're ready to talk about medication. It may not be that they're ready to enter into a program, but they're ready to read some materials, maybe join a support group. So giving them those opportunities. So some people might say, well, depression is depression. How is this different? Obviously, the time frame we know is different. That can be part of it. But what we also see is qualitatively. One way to describe it is that moms will report that they feel like this has become who they are, that it's not an illness that's separate from them. It's just become their identity. So feeling that guilt, that despondence meaning loss of hope. So that's some hopelessness, loss of courage, loss of feeling like I can do this, that impact on self-esteem when they're already, having these identity changes and then feeling like I just can't do this. And that sleep disturbance can be pretty significant. And of course, the impact for parent and infant interactions, which is so important in that, first year of life, can be impaired. Karen Kleiman, again, talks about the analogy of losing a kidney versus losing a breast, and of how both of those things are difficult experiences, but one has far more implications for identity and sexuality and things like that. And then even understanding that perinatal mood disorders are different in amongst themselves. So Samantha Meltzer-Brody wrote a lovely article about the different types of postpartum depression that we might see. And then another thing that stands out, and a reason that's a barrier to treatment, that a reason that's stigma, is that fear of being labeled a bad mom. There's a fear of medications, which we'll talk about as well, but that fear of being labeled a bad mom because of protective services. And unfortunately, this has happened. where moms have reported their symptoms and, they were, instead of being cared for, they were punished. And so this is something that moms who have a lot of anxiety will tend to Google a lot, and they may find things like this, which then prevent them from getting care. So it's really important to continue to talk about this. So our fellow providers know that, this is something where, as this author says, no one should be afraid to be truthful with a doctor. So moving on to anxiety disorders, again, as we talked about, prevalence rates ranging significantly. With anxiety, I believe that rate is very broad because it's very difficult to tease out depression from anxiety sometimes. A lot of times they come as, a package together. Sometimes we see depression first, sometimes we see anxiety first, but a lot of times they're coming together. And then with obsessive compulsive disorder, pregnancy onset rate of 13 to 29%, postpartum onset 2 to 15%. And then that postpartum exacerbation, again, you see a huge, huge jump. So these are folks who previously had a diagnosis of obsessive compulsive disorder. Maybe it was treated, maybe it wasn't, but in the postpartum, it's gotten so much worse. So if they have a tendency to have some OCD type of thoughts and behaviors, it can get significantly worse. With perinatal panic disorder, 2 to 11%, and post-traumatic stress disorder, PTSD, 3 to 19% of the population may experience some of these. So the symptoms that we see: worry, certainly worry about the baby, worry about oneself, dread, specific fears, ruminations, phobias. One of the phrases that we hear so frequently is, I can't turn my brain off. I'm exhausted. I'm so tired. Why can't I turn my brain off? So the patient may be reassurance seeking. And if they start to feel like their partner has been exhausted with reassurance seeking, they may turn to the internet and seek reassurance there, which is not always a great source. Unfortunately, we can get a lot of bad information there. Restlessness, fidgeting, feeling unsettled, that notion of anything that's going to happen is just going to be bad. So one of the questions that you might hear from a mom with a lot of anxiety in their pregnancy is, will my anxiety hurt my baby? So how are you going to answer that? We're going to talk about some of the risks of having, depression and anxiety during pregnancy. And so being aware of how to answer that in a way that doesn't contribute to anxiety is going to be really important. In perinatal obsessive compulsive disorder, those intrusive thoughts, those ego dystonic thoughts that I mentioned can take on a whole new life. They can become more significant. So they're like, TikToks or little videos almost that play out in someone's head. It may start out with, the babies in their arms, and they suddenly see a flash of themselves accidentally dropping the baby. And then it can evolve into they're feeling like they're gonna do this on purpose. They don't trust themselves. So there's a lot of anxiety around having the thoughts. And these thoughts can happen in the non-birthing person as well. So it's, something that can happen in all parents in the postpartum. And we may not see depression initially because they're starting to not trust themselves. They're starting to feel like, I'm a bad mom. We may start to see depression develop over time, especially without treatment. There may be hypervigilance in protecting the infant, feeling like no one else can care for this baby but me. Or conversely, they may feel like I can't be trusted. And so, checking in on that attachment and, being able to encourage mom to have interactions and to encourage mom to also take a break when needed. So again, 70% of women who have previously been diagnosed with OCD experience a recurrence in pregnancy. There's something about the way our brains are designed to be highly focused on baby and, things around baby that really can contribute to having some of these OCD type of symptoms. And then with panic, I'm sure a lot of you know what a panic attack looks like. It's definitely that sense of fear. There's a lot of physical symptoms, typically increased heart rate or palpitations, sweating, feeling like you can't catch your breath, feeling shaky, maybe even feeling faint, nausea and abdominal distress. So it's a very physical experience. It's very much a fight, flight, or freeze of fight response. A lot of moms will report that they've had their first panic attack or their worst panic attack during labor and delivery, in particular when there's unexpected things that happen, like an unplanned C-section. One mom that I had worked with, she had 3 lovely vaginal deliveries for her first 3, and her 4th delivery was a cord prolapse. And that was a very unexpected experience, even though it wasn't an unplanned C-section, it was something that caused her to have a panic attack. So understanding that when there's panic disorder in pregnancy, some of those physical changes, because there's more pressure on the belly and more difficulty breathing, that can contribute to increased symptoms. And this is a time of increased isolation as it is, because moms are trying to stay home and stay away from getting germs and all those kinds of things. It can lead to even more agoraphobia. So even once, there's been a sense of, okay, now I can get out in the world, there may be some more fear around leaving the home. So some of the themes that we hear about in postpartum anxiety and OCD is a mom who may say, I'm checking on the baby all the time. They may feel like, I have to set my alarm. I have to, get my phone and make sure that I'm, checking on the baby on a regular basis. Again, unable to be relaxed, unable to feel like I can be, settled down, quieted down. If a baby has been ill, if the baby has been in the NICU, for example, there may be a big concern about germs. So that may be, something that I've seen is a mom who continues to wear gloves, even months after baby's been discharged, and just constantly is wearing gloves for protection. Again, that feeling that no one else can care for the baby but mom. Another mom that I worked with didn't allow anyone else to touch her baby for a whole year postpartum. Just her and the pediatrician were the only two people allowed. So that wasn't very comforting to dad or to other family members. But the good news for all of this is that treatment works. So once she got into treatment, second baby, she had a very different experience. And as I mentioned, there's a worry about medications. So medications that can be really helpful with some of the OCD or anxiety symptoms. Moms will look up a lot of bad information and be very fearful of the effects that it could have on baby in utero or through breast milk. So these are really important to be able to tease out, and we'll talk about that more in a little bit as well. And again, that fear to talk about those intrusive thoughts, because if the intrusive thoughts are misunderstood as mom wants to drop the baby instead of mom is just having these anxieties about dropping the baby, then that can lead to a DCFS call. And then with post-traumatic stress disorder, some of the symptoms that we see would be nightmares, flashbacks. If you're meeting this person who is in labor and delivery, it may seem like a patient who is quote unquote a difficult patient. They may react strangely in labor and delivery. They may be dissociating or having experiences where they feel like they're shut down or they're not listening to you. There may be hypervigilance, asking about all the details of everything that's happening, and a sense that they're trying to control everything. Their PTSD, if they do have a previous trauma, may involve something with healthcare. So they may have a hard time trusting healthcare providers. So being able to provide whatever support is really helpful. And then avoidance. So they may have a hard time getting to appointments because it reminds them of some things that are that have been traumatic for them. And some of the themes that we hear about in perinatal PTSD, I think that we all understand that having a baby, being pregnant, is a very vulnerable experience, no matter how you go through it. And of course, labor and delivery as well, no matter how you go through it, it's a vulnerable experience, which can very much feel like a previous trauma. So there's a sense of lack of control, lack of their voice being heard. So whenever we have that chance to work with a mom who has had a history of PTSD prior to delivery, we do try to develop a birth plan. We call it positive birth preferences. It's not a long document about all the little details. It's really about how to manage symptoms, how to manage anxiety. It's really a tool for both the provider and for the patient to have the best experience possible in labor and delivery. And I think it's really important to manage expectations. If there's someone who is thinking that this is all just going to go wonderfully and smoothly, and not having any idea of what are some of the possibilities of labor and delivery, that can lead to some other experiences that we'll talk about a little bit more about later. So another book by Karen Kleiman. This is, I think, the third time I've mentioned her. We love Karen Kleiman. She wrote a book called Dropping the Baby and Other Scary Thoughts. So sometimes even just saying there's a whole book about this topic can be helpful to moms to understand that they're not weird, they're not alone. This is something that happens. So some other thoughts. So that excessive worry, the what ifs can be, what if I don't breastfeed my baby every night? Then my baby will, not get all the nutrients that they need to develop their brain appropriately. And then they won't, get good SAT scores, and then they won't get to Harvard, and they'll never be a doctor, right? Like, so they open kind of all the possibilities of the what
I
ifs.
pushed for it. Huh? I pushed
Um,
for it. They did it.
And so then rumination might be, something that happens especially at nighttime when there's a difficulty turning their brain off, thinking about, oh, this is just going to go on forever and ever. Obsessive thoughts may be around, things that they're experiencing in their home. Like they might be, cooking in the kitchen and they start to think, oh my gosh, this knife could fly out of my hand and hurt the baby. So then, all the knives get removed from the home. So things like that. Intrusive memories are typically of either previous traumas or possibly of birthing experience that has been traumatic. And then catastrophic misinterpretations are, physical symptoms that may be interpreted in ways like, my heart is racing, I must be dying. Another example is a patient that I worked with on our behavioral health hospital who was on the eating disorders unit, had been diagnosed with anorexia, but she had had significant hyperemesis throughout her whole pregnancy. So even though she was in the postpartum, she still did not trust anything to, be appropriately swallowed and digested, and therefore was not eating. So it was not really a true anorexia, but it was more of a catastrophic misinterpretation. So this is from Patrick McGrath, one of my colleagues, and he is an expert in OCD and anxiety. And he just outlined, when anxiety is taking up and OCD symptoms are taking up too much of our time and signs for getting help. So if there's rituals involved, if there's, if they're taking up a lot of time during the day, if other people are starting to get used for reassurance, if you feel like you might be embarrassed if others knew what you were doing, if you feel like, how does everyone else get everything done? Because I have so many steps that I need to take. I always have to check the stove 5 times before I leave. I always have to check the outlets 10 times before I leave, things like that. If you are having thoughts about your baby that disgust you, if you think that you could be harmful. So those are all signs that we can share with our parents for reasons to get help. And then some common distortions with anxiety, which can be helpful to point out to patients that these are not true. This is your anxiety telling you like, it's going to be the worst thing in the world and I will die. So it's going to be awful, or that it's definitely going to happen. There's no question that, the ceiling is going to cave in today, or that I just won't be able to handle it. And so one of the things I like to remind moms a lot is everything you've ever worried about, everything you've ever ruminated on, and everything you've ever been distressed over, you have handled. And how do I know that? Because you're sitting in front of me. So you may not have handled it in the perfect way, but we can talk about perfectionism, but you've handled it. And so your anxiety is lying to you when it tells you that you will not be able to handle it, or that it will definitely happen, or that it will be the worst thing in the world. So moving on to psychosis. Prevalence rates, we talk about 1 or 2 in about 1,000 birthing persons. Being aware that someone with a bipolar symptomology has an increased risk rate of 25 to 35% of having postpartum psychosis. In fact, 50% of women who have bipolar disorder are first diagnosed in the postpartum period because of all of the vulnerabilities that come in the perinatal period with hormonal changes, sleep changes, responsibility change, the whole cascade of changes that happen. So women who have bipolar disorder have a high risk rate of being admitted to the hospital within about 30 days of delivery because of the psychotic episodes that they may have. So what we might see in psychosis, this is a long list of symptoms because there's a lot of different presentations. This should also maybe be postpartum psychoses, right? So just as we were talking about, there's different types of depression. We do also see different types of psychoses. So there may be agitation, lability, like going from one mood to another, with a lot of mood changes, confusion and disorientation. Again, big changes from extreme fatigue to frantic energy. Bizarre thoughts and hallucinations that do often have to do with the baby. I've had moms who think that this baby has destroyed my marriage, and the partner says absolutely not, but mom is convinced that that's the case. Rapid speech with thoughts that are difficult to interrupt, with thoughts that don't seem to be making a lot of sense, aren't quite clear. suspiciousness and paranoia, memory loss. It can look a lot like a mood disorder. And it typically, and again, this is typical, this is not for all cases, but it typically peaks within 3 weeks of birth. Another thing that it correlates with a lot is with discontinuation of breastfeeding. So that is always a time to also be aware to, pay attention to folks who may have some predisposition to psychosis. And then it's typically, there's not depression and anxiety, although there are some psychoses that are depression related. That's a smaller minority, and it's unrelated to environmental stressors. So it can be someone with, a wonderful psychosocial profile, but they still can develop psychosis. So now moving into risks and effects with perinatal mood disorders. So I'm going to dive right into the most significant risk, which is death. So from the 2016 and 2017 Maternal Mortality Review Committee data, you may have seen this in a previous presentation, but 40% of pregnancy-related deaths involve mental health conditions. So this is, really behooves us to be aware and be involved in taking care of this. And one of the things that, several of the things that we really notice as a big theme in contributing factors to suicide and overdose deaths in the perinatal period, lack of coordination, which is really a universal issue in the data from the MMRCs, missed screening opportunities. So in Illinois, we do have a screening law. We were the second state in the country to mandate screening for postpartum depression, but there's clearly a need to fulfill that and to also screen for substance use disorders and intimate partner violence. Low availability of treatment services, especially in rural areas, especially for patients with public aid or no insurance, and even with insurance, sometimes there's limited coverage. Inadequate referrals, so lack of, making or getting to those specialist appointments. Warm handoffs is something that we probably talk about multiple times at every MMRC meeting. And then inappropriate psychiatric medication management, which we'll talk about, or inadequate psychiatric medication management. So some providers lack that knowledge and think that they are doing a good service, but unfortunately, we would like to educate them more if possible. And then limited awareness. So we really just want to, continue to provide education and opportunities to learn about, awareness and signs and symptoms. So who gets perinatal mood disorders? What are the risks as far as, the populations that might get it? This is a long list, but if you can break it down into the bio, the psycho, the social, hopefully that's helpful. Bio, any previous mental health treatment, whether it's, substance use disorder or eating disorder or depression or anxiety or family history, those are people who are, concerning. Social, do they have support people around them, support people that they rely on and that they actually can turn to and believe will be supportive? And then do they have stressors like job loss, or do they have a partner who is recently deployed, things like that. So the bio, the psycho, the social is what we're looking at. And then I also look at another type, another part, which is personality type. And a lot of folks who do experience perinatal mood disorders define themselves as type A, or maybe it's just women, I don't know. So this is a drawing from someone who whose partner said, "What are you thinking about?" And so she wrote it down. She wrote down all the things she was thinking about. And some people talk about this as the invisible load of motherhood, or emotional labor, but being aware that some folks who identify themselves as perfectionist or type A or very structured can sometimes have a more difficult time in the postpartum period. And so why does this happen? So many things that contribute. It's not just the hormones. It's, going from the bottom, social rhythm changes. The patient, you might hear say, I really love my time with my friends and I don't get to see them so much. Or next one is about identity. I wasn't prepared for what it felt like to be responsible for another life. And then, of course, hormonal changes. Maybe it's someone who has had a previous history of PMS or PMDD, and those things can contribute to all of this. And of course, stressors, genetic susceptibility, that's where we talk about trauma, certainly, and current stressors, sleep changes, We know that sleep changes, because of the circadian rhythms are affecting mom and are affecting how sleep is delegated throughout the night. And we also know that pain and inflammation are linked with depression. There's plenty of studies on this. And what we can see is someone who comes in and says, why is this happening to me? Why is this happening now? And so I might take this out and say, well, you just told me about all of these different things. And, and then physical activity changes might be, I used to rely on my 2-mile run every other day to keep me feeling good. And someone who's, 38 weeks pregnant is probably not doing a 2-mile run. And someone who's 2 weeks postpartum is probably not doing that run. So all of these things can come together. And that's why we talk about this being such a vulnerable time. And it's important to recognize all of these. So in just a little bit more detail, the identity changes that can contribute to that. There's some really good social media that's out there. There's a lot of bad, of course, but this happens to be a good one, talking about all the different identity changes that someone might experience. This is that hormonal shift, as we talked about. So many hormones keep going up and up and up and up and up to keep us pregnant. And once that placenta is delivered, these bottom out. Huge, huge change. And I want you to think about this same graph in terms of expectations. So if you think about, I'm about to give you a cookie, your dopamine is going to go up. And then if I don't give you that cookie, it's going to go way down. So if you're thinking, I'm going to have, a natural delivery and I'm not going to have a tear and I'm going to have a, wonderful breastfeeding experience. If you're expecting all those things, or even one of those things, and it doesn't happen, that's another big crash. So we're talking about a lot of neurotransmitter and hormonal changes that can really contribute to not feeling good. So speaking of trauma and perinatal mood disorders, women who have experienced trauma certainly have an increased risk of perinatal depression, ACEs, adverse childhood experiences associated with increased risk of postpartum episodes, multiple ACEs, multiple biologic changes, increasing allostatic load. So understanding that, I would say probably 80% of the moms and families that I work with have a previous history of trauma, and that is contributing to what they're experiencing when they're having a perinatal mood disorder. And again, treatable, something that we can definitely help with. And when we see postpartum PTSD, some of those risk factors, emergency C-section, any high level of obstetric intervention, forceps, vacuum, especially things that were just unexpected, feeling like no one was listening, feeling like voices were being not heard. And this is where we might see some, racial bias as well, people feeling like they're not being respected and listened to. Premature or infants that just don't look like what they expected their infant to look like. Again, any psych history, and it's more common in first pregnancy. So when we're doing, when we're meeting with patients, it is important to ask about their birth story and find out if this is what's contributing. If we happen to have the benefit of seeing a patient early from their postpartum experience, if it's, day 2 or day 3 even, one small thing that we can do is invite them to play a game of Tetris. There's a couple of studies that show that there's something about playing a game like Tetris, about putting things in places that can help minimize some of the effects of PTSD. Can't hurt, might help. So when we don't treat, when perinatal mood and anxiety disorders are untreated, what do we see? In depression, small for gestational age, low birth weight, preterm birth, more preeclampsia, people who aren't getting to their doctor's visits, who aren't taking their prenatal vitamins, who are using more substances to manage their mood disorders. I know that I'm sure you've seen the increased use of marijuana, higher maternal BMI. With bipolar disorder that's untreated, we see more delivery inductions and C-sections and preterm births, more gestational hypertension and hemorrhage, placenta previas, small for gestational age, and low birth weight. So these are all very concrete, very real things that happen when we do not treat perinatal mood and anxiety disorders, and why it behooves us to do so. So what we see in the infant, also, risks that we can prevent, elevated baseline fetal heart rate when mom is not treated, more likely to be fussy, more likely to be admitted to the NICU, just poor habituation and poor orientation, poor growth, more risk of infection. and that change in vagal tone that is, not as we want it to be. So then further down the line in offspring, children are just have more difficult temperaments, more distress, higher rates of depression, childhood hypothalamic pituitary adrenal abnormalities, and even lower IQ scores further down the line. And in parenting, what we see, parenting may be intact. Another parent climate statement, this is the smiling depression. As you saw from Adrienne at the beginning, she works hard to smile and coo and have positive interactions with her child, even though she's feeling awful. But these risks do still include that difficulty reading baby's cues and sort of being naturally enriching in ways that can be supportive to baby's growth and development. And of course, the risk of suicide, as we started to talk about, it may be increased as well when the pregnancy is unwanted and when a pregnant person wanted an abortion but could not obtain one, when there's been partner abandonment, when there's been prior pregnancy losses or children's deaths, and in adolescence. So, again, things to be aware of when we're doing our intakes and learning about our patients. And the risk of harm to child, again, it's much higher in postpartum psychosis when we have some of those, unpredictable thoughts and irrational beliefs, delusions, hallucinations. Very, very important to educate the family about illnesses and risks. Very important to get them on board and supporting this family member and what's going on with them. So having them understand the unpredictability. Just because she's looking great and responding appropriately now, we still have to remain vigilant until, we start to really see a consistent waning of symptoms. So looking for those irrational fixed beliefs. So screening is so important. Screening recommendations from the American Academy of Pediatrics, from ACOG, from all over the place recommends screening. Screening is a tool. So just remembering that screening is definitely not the end all and be all, but we want people to screen. And I'm not highlighting a whole lot of specific studies, but this one in particular, I think, is just a really nice highlight in a study of 391 outpatients, women screened with the EPDS. The detection rate was 35.4 versus 6.3 without the EPDS. So one reason to screen so we can detect and then take the next steps to treatment. So just another way to look at being aware, assessments during the perinatal period. So always assessing for mood, always assessing for what's going on, knowing psychiatric history, knowing that abuse trauma history, getting that down. And maybe even if there is a history, then checking in on a regular basis, if that's being treated, if that's still being a concern, and then for adverse obstetrical outcomes, of course. So treatment in pregnancy, a lot of women do not want to take medication in pregnancy. So we talk first line of psychotherapy. Some of the best studied is cognitive behavioral, interpersonal. Interpersonal talks about identity changes. Imagine that. How helpful is that? We talked about how important identity changes are. Groups are helpful. Peer support is well accepted. There's a lot of benefit that we see having someone who understands go walking through it with you. Light therapy. So if that's natural light, going outside within the first hour of waking. If it's not, then light box can be super helpful. And pharmacology will, like I said, a lot of people avoid, but it can be very helpful and essential for many, many patients. Electroconvulsive therapy is still widely used in pregnancy when needed, and it's quite safe. And some emerging treatments, transcranial magnetic stimulation, not a ton of data, but there's some promise with some of that. And then omega-3 fatty acids are really adjunctive because they help with inflammation. So as I mentioned, interpersonal psychotherapy, interpersonal therapy, and cognitive behavioral is really key. Any type of supportive therapy can be helpful, but I think what's really helpful is to have a provider that has the perinatal mental health certification, the PMHC, which we helped develop through Postpartum Support International. As you heard, that's something that I was a part of. And we're very proud that so many people are seeing the importance of being specialized in this area. So another treatment is exposure and response prevention, and this is especially true for anxiety disorders and OCD. And exposure and response prevention, what we do is putting a person into the situation that they're fearing, not day one. That's not like, I have feared elevators my whole life. We're not going to throw you on an elevator day one. We're going to get you ready. We're going to give you some tools, and then we assist you in dealing with it. Assisting the person does not mean you're giving them reassurance, but understanding that, you will be able to handle it. So we're going to continue to help support them through that. So for medications, why should not prescribers have to talk about medications in general? Here's why. Pregnant people are desperate for solid information on medications, and there are far too many mixed messages coming at them. Also, too many well-intentioned prescribers advise patients to stop psychiatric medications. If there's one PSA that I could put out there is to take your time. Don't cold turkey anything when you find out you are pregnant. And there's really few psychiatric medications that are an absolute no in pregnancy. So understanding that is important. So being able to talk about the risks versus benefits with patients is important. It should be discussed in a way that doesn't add to their guilt. Like I said, guilt is such a common experience. Understanding that reproductive psychiatrists are few and far between. So it does fall to a lot of us who are non-prescribers to talk about it. Being able to recommend the Postpartum Support International Consultation Service. It's a free psychiatric consultation service for providers who are prescribing medications during pregnancy and breastfeeding to talk with a reproductive psychiatrist. So hopefully your provider is willing to do that. I, as a non-prescriber, may need to consult with the patient's OB/GYN or primary care saying, I recommend this medication. So I do know about medications, even though I'm not a prescriber. And then I refer patients when they are Googlers to these evidence-based places to look for medication information if they really want to look for medication information. So this is Dr. Zach Stowe. I had the pleasure of meeting him. I've had his quote on my education for years, which he says, I've spent the last 10 years of my career worrying about the impact of medications. I was wrong. I should have been worrying more about the impact of the illness. So it's important to recognize that for a pregnant person, exposure occurs, whether it's to the illness or to the medication, right? So it's kind of more of a risk analysis, really. So being able to talk about that again in a nuanced, caring way, because every person deserves a detailed discussion of risk and benefits so they can make a decision that considers their unique situation. Very important. I think any discussion of medication needs to include Sage Therapeutics because this is a very promising medication. They developed Zulresso, which is the first medication specifically studied from beginning to end just for postpartum depression. It is FDA approved, but it's difficult to obtain. It is an intravenous, it's an infusion over 2.5 days. And in Illinois, there's only 2 sites that offer the infusion. So it's difficult to get to at this point, unfortunately, but it's very effective. There's a lot of people who go in with a very high EPDS score of 27, and they leave with an EPDS score of 0. So it's quite effective and long lasting. There's currently a similar medication that's an oral version of Zulresso that's being studied and working its way through FDA approval for both postpartum depression and generalized depression. So if you're interested in finding out more, go to the Sage Therapeutics website and they can find out more. So role of support group is very important. It's reinforcing, people share experiences, it becomes a shared problem. A lot of the themes that we hear about in group, guilt, medications, lack of connection to the baby, working mom versus staying at home mom, all these kinds of different things that people are just so in need of having a place where they can share this with someone who understands. So the support group can be super helpful. And as I mentioned, this may be the place where they're comfortable starting. This may be the entry point into care. Complementary and alternative treatments are important to understand too, because as I mentioned, many birthing persons will not want to consider medications, but will consider natural treatments. So it is important to understand which are the evidence-based treatment options. That herbal remedies, vitamin supplements, very limited with data, especially during pregnancy. Non-evidence-based options that are very popular, and we try to do our best to discourage in a kind and gentle way, placental encapsulation and cannabis. And then for more information on complementary and alternative womensmentalhealth.org, where they talk about light therapy and massage, acupuncture, and exercise. And as I mentioned, omega-3 fatty acids, folate, those are good options. So resources, I'll take a minute to talk about my program. So our program at Ascension, Illinois, we started here in 1999, and we support our OBs and clinicians and folks to make sure that any woman that comes to us has an opportunity to get the care that she's looking for. We do outpatient consultations, and that's for anybody in the community or even further away. So it doesn't have to be someone who's just an Ascension patient. Anyone can come to us and get a free assessment, and we provide them with resources, referrals, information, support, blah, blah, blah. We do on-unit assessments with our team here. We have support groups. We have a Polish language support group out of Elk Grove Village, and we collaborate a lot with community agencies. In 2015, we started the intensive outpatient program. It still remains the only one in the state. It's 4 days a week. At this point, it's 9 to 12:30. This is the virtual version, but we are soon going back in person, but we will still continue to have a virtual option as well. So these folks get perinatal psychiatry, group-based support, education that's very perinatal specific. And there's our phone numbers. The second one is the phone number to my program, and we do a lot of the intakes for the intensive outpatient program. So prevention, everything I talked about with risks was in the guise of this is how we prevent, is understanding risks and preventing some of these things, but assessing and recognizing early, doing individualized plans, no cookie cutter treatments, listen to moms, meet them where they're at, increasing education, as I like to do. If we could start to get the US to walk the walk of, providing parental leave, we say we're a family loving country, but I don't see that. Cultural shifts that I see, men being much more involved. They are loving their parental and dad roles, which is fabulous. This is a big change I've seen over the last 20 years. The reduction of mental health stigma is amazing as well. We still have a long way to go. And then what I encourage moms to do is really understand yourself before you have that time to get pregnant. If you can know your love languages, if you can know your attachment styles and all those things, that can be helpful. Having realistic expectations, and then understanding that genetics is going to continue to play a big role in mental health and increasing predictive possibilities. So we may be able to at some point do a blood draw and say this person is going to have this depression or not. Some resources, we are blessed to have the North Shore Moms Line here in Illinois. There's the suicide hotline, and then there's a new maternal mental health hotline as well. Additional resources in Illinois, Postpartum Depression Illinois Alliance, and then some podcasts and things that I think are wonderful. So just ones that I'm biased towards. And I tried to wrap up right at the hour. So, whew.
Thank you so much. Yes. So now I know we have a few questions in the chat box for you. Callan asked, is there any emerging consensus on whether universal screening for a history of PTSD during pregnancy is beneficial, or discussing the possibility of labor and delivery triggering prior trauma with patients who have documented PTSD in their health records?
Yeah, definitely. It's worth, we encourage people to do the ACEs questionnaires and to have that history. I can't point to any of the studies, but I'm really basing that on clinical experience, that it's very helpful for people to be prepared. And so, having them understand what labor and delivery can look like. It may almost be like an exposure and response prevention, being able to go into a delivery room if possible, to see some videos for how things may look in labor and delivery. So preparing them is very helpful. It's very important. But yeah, I think being able to have that discussion and being aware of it is very helpful.
Thank you. And one last question that we have in the chat from Erica. She asks, what are your thoughts on the book, Good Moms Have Scary Thoughts, A Healing Guide to the Secret Fears of New Mothers by Karen Kleiman? I know you mentioned this.
Yes, Karen Kleiman is great. I think it's a great book. if moms are having scary thoughts, I would definitely encourage them to, utilize that book. I've Many of our moms in our intensive outpatient program have found it to be really helpful to normalize, to understand how to cope. And yeah, we think it's great.
Perfect. Thank you. And then Liliana asked, do you have any resources for postpartum depression affecting partners?
Yeah, there's a lot of great resources on Postpartum Support International that are dad specific. They do also have some supports for the LGBTQ community, but there, as far as dad's resources, you can always email me too. I have a whole list of things that I send to dads when they're reaching out and they're struggling as well.
Perfect. We have a question from Mia asking, do you have any specific resources to recommend sharing with pregnant people? Any brochures or any handouts?
There's a lot. Yeah. If I could give every birthing family the book, The Postpartum Husband, that's one that I would definitely recommend. I'll go back to this here, The Beyond the Blues. So this is a nice short book, and I think they've also issued it in Chinese and a couple of other languages. So if they're able to read books, that's great. And that otherwise, I would go to postpartum.net, Postpartum Support International. There's all kinds of specific pages and resources that can be printed out from there for free. So that's a great place.
Perfect. Thank you. Does anyone else have any questions? You can unmute yourself and ask. If not, I think that was all the questions in the chat box.
Thank you.
Yeah.
Stop share. You want powers
Yes.
back? Mm-hmm.
Yeah. Perfect. Thank you so much. Yes, and I know someone's asking about, we will be providing a post meeting follow-up email, and we'll be sharing the slides that were shared today. I'll go ahead and share my screen. Oops. So from EverThrive's, so for EverThrive, we do have two resources we wanted to share with you all. You might have already heard of this, or you might already be utilizing these two toolkits in your practice. So we do have on our website, we do have the Healthy Choices, Healthy Futures toolkit, and it's perinatal education that you may all use with your participants and your clients. And that can be found at our website, EverThriveIllinois.org. And then we also have The Gathering. So for more information on this, you can go to thegathering.everthrive.org. All right, so like I mentioned before, any and all presentation materials that we share today will be emailed to all of you who have registered. But so before we end the call, because I know we're a few minutes over, there is going to be a brief anonymous poll that I'm going to pull up momentarily. So just please fill out the poll if you can, and then stay tuned for more information. We will be having the last town hall for this quarter next month in June. So stay tuned for that. We will be sharing that information shortly. And so I'll go ahead and
Elizabeth, somebody in the chat,
yes.
Charlotte asked, will the recording be shared as well in that email?
Yes, definitely. Yes. So we will also be sharing the recording to you all. Anyone who registered will be sharing the recording as well. So I'll go ahead and pull up the poll here shortly. Here we are. So you'll see the poll go out to you. If you can just fill that out. And we'd love and appreciate your feedback.
You're at 100%, Elizabeth.
Thank you. Okay, perfect. So once again, I'd like to thank you so much, Lida, for your presentation and for being able to guide us today through our discussion. We appreciate it so much. And if anyone doesn't have any last questions or any comments, we'll go ahead and end the town hall. And again, for everyone who is here today, we will share out the recordings and the PowerPoints that were shared during today's presentation. Right. Thank you so much.
Thank you.
Thank you.
To end record. Do you want me to click stop sharing, Elizabeth?
Yes, please.
Okay. Share results. Okay.
Yes.
Stop
Perfect.
sharing. Okay. I just want to make sure you can see them.
Yep, I can see it. Thank you.
Did you stop recording, Elizabeth?
Let me go ahead and go to that real quick. Hold on.